The sacrum is a topic that a lot of students have difficulty with understanding, whether it's because there's tons of different motions, the diagnosis is difficult to make, whatever reason it is. But what we're going to do in this lecture is try and make it as simple as possible so that you can get the questions correct on the exam. The first part of the lecture, we're going to talk about the motions that the sacrum goes through around what axis. And in the second part, we're going to make a giant flow chart that will give you the diagnosis of the sacrum based on your findings. So we're going to start off with motions of the sacrum. So we're going to draw out the sacrum from the posterior side. So we're on the posterior side of the patient. We're looking towards the sacrum. This is going to be the base, and this is going to be the apex. I drew it like this to make the angles very clear of where the sacral sulcus is and where the inferior lateral angle is. These two landmarks are going to be important when we start making our diagnosis. The next thing that you need to understand is how the sacrum moves. So imagine that I'm on the posterior side and this is the anterior side. My hand's going to be the sacrum. If the base of the sacrum moves anteriorly, this is considered sacral flexion. If the base of the sacrum moves posteriorly, this is considered sacral extension. So flexion forward, extension backward. This motion occurs around an axis. Now remember from a previous lecture, we had talked about an axis just being a linear point that something rotates around. So for the sacrum, you have one axis, sacrum is attached to it, flexed and extended around the axis. So from a posterior side, flexed, extended around the axis. There are a few different axes, 5 in total, and you need to know what motion occurs at what axis. So to start off with, I'm going to talk about the midline axis. This axis is where postural motion occurs. So writing it out down here, midline is where postural motion occurs. So what do I mean by postural motion? When the patient is standing and he tips forward into flexion with his spine, the sacrum has to compensate. When you flex forward with your spine, the sacrum compensates by moving into extension around the midline axis. So it's opposite. So if you go into extension with your spine, your sacrum is going to move into flexion on the midline axis. So writing that out, if you flex the spine, you are going to extend the sacrum. If you extend the spine, you are going to flex the sacrum. So the next two axes that we're going to talk about are the oblique axes. There are two of them. There's a right oblique and a left oblique. The right oblique is named right because it goes through the right sacral sulcus. So right oblique. And the left oblique axis goes through the left sacral sulcus. Left oblique. So writing that out, weight on left leg means that you're engaging the left oblique. And weight on right equals right oblique. The next axis that we're going to talk about is the superior axis. And there are two motions that occur around the superior axis. You have respiration and cranial. So how does this work during respiration? When you take a breath in and you inhale, the sacrum is going to go into slight extension. It's going to tip posteriorly into extension around the superior axis. So it's going to move like this, posteriorly. When you exhale, the sacrum is going to move into flexion. The base will move anteriorly around the same axis. So writing that out, superior axis is for respiration and cranial. Inhale means that the sacrum will go into extension. And when you exhale, sacrum goes into flexion. The other movement that occurs around the axis is cranial motion. So in this lecture, I'm just going to introduce the words, so just memorize the words for now, knowing that during a later lecture that's devoted 100% to cranial, we'll go over what everything means. So just remember what I'm writing down on the board. So for cranial, which is also called inherent sacral motion, when the SBS goes into flexion, your sacrum is going to go into extension. And when you're in the world of cranial, sacral extension is also called counternutation. When the SBS goes into extension, the sacrum is going to tip forward into flexion. And this motion in the world of cranial is called nutation. Don't worry about what these mean just yet. We have a lecture devoted all to cranial later in the series. So now that we understand how the sacrum moves, we're now going to go over how do you diagnose the sacrum. So you need three things in order to diagnose the sacrum. You need to know the seated flexion test, you need to know which side has a deep sacral sulcus, and you need to know which side is the posterior inferior ILA. So what do these three findings mean? A seated flexion test is when you have the patient seated on the edge of the chair or edge of a table. You have your thumbs hooked underneath the patient's PSIS, and then they bend forward into flexion. As they go into flexion and you're monitoring with your thumbs, you take note of which thumb moves first, moves fastest, or moves furthest. Whichever side that happens on is what side is dysfunctional for the sacrum. So it's telling you that that side of the sacrum is mobile. And this can either happen on the left side or on the right side. So seated flexion tests, it's either positive on the left or positive on the right. Next, you have the sacral sulcus. So what you do here is you have the patient laying on their stomach, you palpate the sacral sulcus, and you tip your thumbs inward into the sulcus. And what you're doing is feeling for which sacral sulcus is deep and which sacral sulcus is shallow. So you can either have deep or you can have a shallow finding. It's important for you to understand that for the sacral sulcus, you can either have deep or shallow. In order to correctly diagnose the sacrum using our method later, you need to know which side is deep. So if you're given a finding that says that one side is shallow, you need to understand that they're saying that the other side is deep. So if the finding says the right side is shallow, that means that the left side is deep. So always take your findings and reinterpret them back into deep. Now posterior inferior ILA, you march your thumbs down to the ILA, you loop your fingers underneath, and you palpate which side is posterior and inferior. For that, you can have two different findings. You can either have a posterior and inferior side, or you can have an anterior superior side. Just like the sacral sulcus, you need to understand that if you're given one of those findings, you can transfer it to the opposite side. So if they're saying that the right side is anterior and superior, this means that the left side is posterior inferior. And if you want to follow our diagnostic flow, you need to make sure that your findings are posterior and inferior. So always change back to what findings you need for the dysfunction. So there are two different types of dysfunction that you can have for the sacrum. You can either have a flexion or extension dysfunction, or you can have a torsion dysfunction. So a flexion or extension dysfunction. That just means that the sacrum can flex or can extend. This can either be bilateral, where it occurs on the right and the left side, so the entire sacrum tips forward or tips backward into extension, or this can be unilateral, where only the right side tips forward or only the left side extends backward. So you can have a bilateral flexion or extension, or you can have a unilateral flexion or extension. Torsions are a little bit different. Torsions can flex around a certain axis, or they can extend around a certain axis. The way that we say this to one another is by saying right on right, or left on left, or right on left, or left on right. What this means is we are saying which direction the sacrum is rotated and on what axis it's rotated. You name the rotation based on which direction the sacrum is going. The axis that you're going to use to name the dysfunction is the oblique axis. So remember that you name the oblique axis based on which sacral sulcus you're running through. So right sacral sulcus, right oblique. Left sacral sulcus, left oblique. So there are two types of torsions. You can either have a flexed torsion or a forward torsion, or you can have an extension torsion or a backwards torsion. For flex torsions, you can have a right on right or a left on left. If we go back to my pen example, let's say that my pen is the sacrum, or my hand is the sacrum. If we use my pen as an axis that's oblique through the left side, it's going to run right here. If I'm going into forward rotation, it's going to go anteriorly. So it's going to move like this. You always name the direction of rotation based off which way the sacrum is going. The easiest way to think about this is imagine a set of eyeballs on the front side of the sacrum. When I bend forward around that left axis, my eyeballs are now looking to the left, so I'm rotated to the left. If I'm going into forward torsion around a right axis, and I bend forward, my sacral eyeballs are now looking to the right, so it's a right torsion. So now the extension torsions, you can either have a right on left or a left on right. Unlike a flex torsion, where the sacrum dips forward into flexion, for an extension torsion, the sacrum dips backward into extension around that oblique axis. So if you're looking at it from the lateral side, it's going to look like this. If you look at it from the anterior side, it's going to rotate like this, back into extension. You can still name the directionality of rotation based on your sacral eyeballs. If you are rotating around the axis forward, you're rotating to the right. But for an extension dysfunction, if I'm going backwards, my eyeballs are now looking to the left, so it's a left rotation. So looking at it from the forward side, going backward is a left rotation. So this next part of the lecture is going to tell you how you can interpret the diagnostic findings to tell you what the diagnosis is. This is outlined so that you don't necessarily have to understand what each finding means, but you just plug it into the flowchart and get the correct diagnosis. All that you have to remember is that it's a mirror and it's same, opposite, flexed, extended, right. You'll see what I mean as I'm going. So seated flexion test, you're going to have two findings. You can either have it positive on the left or positive on the right. And remember, since this is a mirror, we're only going to go over the left side right now. So the next thing that you do is you assess the side of the sacral sulcus and the ILA. Now remember, when you're interpreting the sacral sulcus findings and the ILA findings, you always want to put it into deep sacral sulcus and posterior inferior ILA. So if they tell you that one side is shallow, the other side is deep. Or if they tell you one side is anterior superior, the other side is posterior inferior. The next thing that you need to understand is that this can either happen on the right side or on the left side of the sacrum. So you have the findings of the deep sacral sulcus and the posterior inferior ILA on the same side. The deep and posterior inferior ILA are both on the same side. So same, or they can be on the opposite side. The next step that you need to run through is comparing the sacral sulcus and the seated flexion test. So you need to identify which side the sacral sulcus is deep on and which side the seated flexion test is positive on. They can both either be on the right or on the left. For this side of the equation, if the seated flexion test is on the left and the deep sacral sulcus is also on the left, they're on the same side. If they're both on the same side, then you know you have a left unilateral flexion. If your deep sacral sulcus and positive seated flexion test are on the opposite sides, then that tells you that you have a left unilateral extension. If we move back up the flow chart to deep sacral sulcus and posterior inferior ILA occurring on opposite sides of one another, next we look at the deep sacral sulcus and the seated flexion test. If they are both on the same side, for example, the seated flexion test is positive on the left, the deep sacral sulcus is also deep on the left, they're telling you it's on the same side. If this happens, then you have a right on right. If they occur on opposite sides, meaning that the seated flexion test is positive on the left and the deep sacral sulcus is on the right, saying that they are on opposite sides, this tells you that you have a left on right dysfunction. So once again, same opposite, same opposite, same opposite, flexed, extended, right. Right, because for both of these findings, it's on a right oblique axis. And if the first one is right on right, the next one must be left on right. Now here's where the magic happens. I took you through every single step. I told you same opposite, same opposite. We went through all the findings. But for the chart, the way that we have it laid out, all you need to do is flip it, like it's a big mirror down the middle. So I can draw this out really quickly by saying seated flexion test on the right, sacral sulcus versus ILA. It's a mirror, so I can say this is opposite, this is same. Next we look at the sacral sulcus and the seated flexion test. Of both of these, we can have them being on the same side or the opposite. Because it's a mirror, it's going to be the opposite of the other side. And with our dysfunctions, we're just going to flip it. So we're going to start out with a right on left, then a left on left, then a right unilateral extension, and a right unilateral flexion. So you can go through the entire flow chart based on left or right. There's a lot to memorize for the flow chart, and if you get frazzled in an exam, it may be difficult to remember everything. So in the next video, I'm going to show you the way that I do the diagnosis, how you draw it out, and once you understand how the motions are working, not only will you get the questions right on the test, but you'll also understand what you're even talking about. So in this lecture, we went over axes of motion for the sacrum, what occurs around each axis, the 3 findings that you must have to get the sacral diagnosis, flexion and extension and torsion dysfunctions, and then went through the very confusing flow chart, which I made easy by saying same opposite, same opposite, same opposite, flexion, extension, right oblique, everything's a mirror. And that is how you diagnose the sacrum.